Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling myocardial infarction, abbreviated as MI, and more commonly known as a heart attack. So let's get started, as always, with our practice question. The nurse in the emergency department is caring for a client with an unstable angina due to an acute myocardial infarction. Which medications would be appropriate to include in the client's plan of care? Select all that apply. We have A, unfractionated heparin, B, nitroglycerin, C, isosorbide mononitrate, D, aspirin, E, diltiazem, and F, metoprolol. Okay, we will circle back to the correct answer at the end of the episode, but first, let's break down what is happening in an MI or a heart attack. Basically, you want to think about your coronary arteries as your heart's personal supply line. So, just a brief recap, your coronary arteries are the arteries that carry blood to the muscle of the heart itself. The heart's a muscle, it needs oxygen too, okay? So the coronaries are supplying oxygen and nutrients to the myocardium. Remember, again, that's the heart muscle. And that lets the heart keep pumping without rest. When one of these arteries becomes blocked, and most commonly by a ruptured, what we call plaque, or an atherosclerotic plaque, that oxygen delivery to that section of the heart muscle is going to abruptly stop. And we know what happens to cells when they don't get oxygen. They suffocate and they die. Okay, not really good if the cells that are responsible for making the muscle of your heart contract start to die. Okay, just a quick walkthrough again. What happens when cells don't get oxygen? They shift into anaerobic metabolism. Remember, we have those two ways to make ATP, aerobic with oxygen, anaerobic without. So when this coronary gets blocked up, the cell has to shift to anaerobic metabolism. And we know that produces lactic acid. The tissue gets irritable. Electrical signals are going to go haywire. Contractility is going to drop. If that blockage persists for 20 to 40 minutes, we will have irreversible cell death. Let's say that again. 20 to 40 minutes of a blockage, and we have irreversible cell death. That cell death, that's the infarction. That's when we have necrosis of the myocardium, that muscle of the heart. You can think of this kind of like a traffic jam in a vital city supply route. So we're on the highway, it's rush hour, and we get a major traffic jam. Maybe there's a wreck. That's our atherosclerotic plaque rupturing and blocking up the coronary artery. Everything downstream from that blockage is going to suffer because blood can't move forward. So pressure builds up behind the blockage. The ischemic area grows, cell dies. As those cells die, they release cardiac biomarkers. The most famous of this is troponin that is going to leak into the bloodstream, and it's what is our diagnostic proof that we have injury to that myocardium. So remember that troponin is a biomarker that is saying, hey, these cardiac cells are dying. Now, of course, the body doesn't take this quietly. It is going to try and compensate as it does. The first thing it does is release catecholamines. This is going to be our epinephrine and our norepinephrine. These two catecholamines will increase our heart rate and our contractility in an attempt to maintain our cardiac output. But unfortunately, with a myocardium that is starving for oxygen, making the heart pump harder and faster only raises the oxygen demand even higher. So we're basically fueling a vicious cycle of ischemia. Now, not all of the myocardium is going to die at once, okay? That area south of the blockage is going to get ischemic, and then cells are getting necrotic and dying, and it's kind of spreading. We call this the zone of ischemia or the zone of injury. And basically, it's going to cause changes in our ECG. And the earlier we recognize it, the better the outcomes are going to be, because basically we can save the tissue that is injured but not dead yet. So when you hear people say time is tissue, Basically, remember we said 20 to 40 minutes and our cells are going to die. We start seeing changes before they're actually dead, when they're just starving for oxygen, but they haven't died yet. So those changes that we're looking for, T wave inversion, that's when we have ischemia. The cells are struggling, but they're still alive. Then when we have active damage, we start to see some ST elevation. And lastly, once infarction has occurred, we get those pathologic Q waves. There is dead tissue, they are not depolarizing. All right, so when we have those T wave inversions or ST elevation, we need to be acting really, really fast, trying to save as much tissue as we can. And how are we going to save that tissue? Let's go into our case study for today so we can walk through a scenario and look at our interventions together. So, of course, you're in the ED. EMS rolls in and they have a 56-year-old male. He is clutching his chest. He's pale, diaphoretic, anxious. And his quote to you is, "It feels like an elephant is sitting on my chest." Now, that's a very strange and specific saying. I have heard people say this more than once, and it's because there's just this intense pressure that they can't explain any other way, like something is sitting on their chest. So that should send your alarm bells off. And the first thing you want to know is, when did this start? So in our case study, the wife is with him. She lets you know the pain started 30 minutes earlier. He was mowing the lawn and he came inside saying his chest hurt. It was radiating to his left arm and jaw. And he was also nauseous and short of breath. Now, he described this as, I just didn't feel right. But when he told his wife the left arm and jaw, she remembered that was a classic heart attack sign and immediately called 911. So now EMS is rolling in. And we have time of onset to the door of the ED is 30 minutes, which is pretty darn good. So hopefully we're going to be able to get in there and do something before it's irreversible damage. So now let's get into his vitals. We've got a BP of 158 over 92, heart rate at 110, respirs at 24, and O2 is sitting at 92% on room air. Take a second and think about those vitals. None of them are like that horrible. I mean, they're not, certainly not like emergent. It's definitely hypertensive. His blood pressure is elevated. He's tacky. Again, 110's a little higher than we would want it to be. And 92%, is lower than I would expect a average healthy 50-something-year-old on room air. But again, not emergent, okay? But we're catching it early. So these vital signs are telling us the story of how his body is compensating. All right. He has had a plaque break off and it's jamming up his coronary artery, that highway bringing oxygen to the muscle of his heart. Blood can't get through, therefore oxygen can't get through. The cells are starving, all right? So we've got ischemia going on, and the heart says, I've got to compensate. Turn up the heart rate, make that heart squeeze harder. Let's send more blood out. So that's why we're becoming tachycardic. It's that catecholamine being released, causing us to be tachy and hypertensive. Ironically, by making the heart tachycardic, the heart is just demanding more oxygen. So it's actually worsening the ischemia. All right, all that aside, looking at those vitals and a classic MI presentation, what's going to be your priority action? Think it through for a second, shout it out. If you're in your car, walking to class, what do you immediately want to do? We need to get him on a monitor. I want to see his cardiac activity. Specifically, I want a 12-lead ECG like yesterday, all right? We need to see if we have T wave inversion, ST elevation, or Q waves. What is going on so we have an understanding of A, is this a heart attack? We don't know that for sure yet. And B, how bad is it? So we get our 12 lead and we have ST elevation. All right. That elevation is in leads 2, 3, and the AVF lead. Now, I've never been that good at reading and interpreting 12 leads. I've never worked in an area where I really had to know that stuff. And it is outside the scope of what you need to interpret for your NCLEX. But if you're a little further along in your nursing journey, maybe you're studying for your CCRN or you've been working in the ED, you might recognize that when we see ST elevation in leads 2, 3, and that AVF, it is indicative of an inferior wall MI. So basically, the gist of it is that whichever leads we see that abnormality in, that tells us which part of the heart muscle is dying. Where is the problem happening? And if we know where the tissue is dying, then we can kind of back up and say, okay, which artery is clogged off? So if it's an inferior wall MI, the blockage is usually in the right coronary artery. That's where the blood is getting cut off. And every minute that passes means more and more tissue that is dying. Time is tissue. So what interventions can we do to save that tissue? Okay. There used to be the acronym MONA. We no longer go by MONA. That's a little bit outdated. So hopefully you didn't learn that. The acronym most schools are using now is ON TIME. Okay, so what interventions can we do to actually help with this heart muscle, help save some of this tissue? Now, there's going to be quite a few people in the room. Hopefully, one of the first things somebody is doing is getting an IV. We want to get some labs and have the ability to give IV medication very quickly. Another immediate intervention is giving aspirin. We like to do 325 milligrams of chewable aspirin. And what this does is inhibit platelet aggregation and keep that clot from growing. So let me be clear, aspirin is not going to like magically fix a massive heart attack, but it can help it not get as bad. It can prevent it from getting worse and worse and worse. So that's why someone starts having angina, we throw some aspirin at it, okay? Go ahead and give them some aspirin. Next thing that we're going to give them is some sublingual nitroglycerin. So this is going to dilate that coronary vessel, therefore reducing preload and making it easier for the heart to do its job. We're just trying to get that oxygen demand down. Now, one side effect that does come from nitroglycerin is a pounding headache because we're dilating those arteries, we get blood rushing to the head. That's normal, tells us the nitro is doing its job. We don't need to report that finding. Couple more meds. Next, we're going to do some heparin. Again, like with the aspirin, we're trying to prevent further clot formation. We want to stabilize the clot until we get definitive reperfusion therapy. We're able to actually unblock that artery. We don't want things getting any worse. And then lastly, because we have a client who is still tachycardic in the 110s, we are going to give some metoprolol. This is a cardioselective beta blocker. It is going to slow the heart rate, reduce that contractility, which therefore decreases oxygen demand. And that's going to give his struggling myocardium a much better chance to rest and recover rather than progressing from ischemia to infarction. Now, none of this is addressing his pain. And he walked in saying it feels like an elephant is on his chest. He's sweaty. He's diaphoretic. You can tell looking at his face, he is anxious and uncomfortable. Now, usually I tell you, pain is not a priority. Pain never killed nobody. But pain control in an MI is not just about comfort. It is also about reducing that catecholamine surge, that epi and norepi, which makes the heart beat faster, jacks the blood pressure up, and worsens our ischemia. So the drug we give for pain in an MI is morphine, all right? That's going to slow things down. That's going to relieve the discomfort, decrease that catecholamine. Again, make it easier for the heart to work so we reduce that ischemia. Okay, so we just did a bunch of things. We gave some aspirin, we gave some heparin, we gave some morphine, some metoprolol. Meanwhile, hopefully someone sent off your labs when we started that IV and drew our labs. And this is going to be a stat lab that the lab should get back to you really, really fast. And what are we looking at? The big one is troponin levels. Remember, that is that cardiac biomarker that basically gets released if heart tissue is dying. If we've got myocardial injury, we see troponin shoot up. Normal troponin is like 0, less than 0.1. It's like tiny, tiny. We only get troponin released when heart cells die. So we're looking for that. That's going to help us make that diagnosis of an MI. Now, in this case, the troponin does come back mighty elevated. Pair that with his ST elevation. And what are we doing? We are getting him right off to the cath lab because we need reperfusion therapy. We're given all these meds to slow the heart down, make it work easier, prevent the clot from getting worse. But that is not fixing the fact that we still have a traffic jam in the major vessel delivering oxygen to the heart. We got to unblock that traffic jam. So reperfusion therapy, that is going to be a percutaneous coronary intervention, or a PCI. That is our gold standard for restoring blood flow. We're going to roll him over to that cath lab, get him hooked up. We are trying to do this as fast as possible. The sooner we get that blockage relieved, the more heart muscle we save. Now, before we circle back to our practice question, because we've gone over a bunch of interventions here, hopefully you're kind of like, all right, I get what an MI is, blockage, and we're relieving the blockage, blah, blah, blah. But I want to point out one thing that we did not do. We did not give this client oxygen. And if you're familiar with the old school mnemonic MONA, we did morphine, oxygen, nitroglycerin, aspirin. Well, we no longer use that acronym primarily because we do not always give oxygen. Let's think back to what this client's vital signs were. O2 saturation was 92% on room air. Does he really need more oxygen? I mean, you could argue it's not perfect, whatever, but if our oxygen saturation is above 90, we don't need to provide supplemental oxygen. So, definitively, we only put on some supplemental oxygen if that oxygen saturation is below 90%. So, it depends on the client. We don't always do it. And with that cleared up, let's go ahead and circle back to our practice question, because as we've walked through our case study, hopefully you will now know what interventions to take in the case of an MI. So you're that nurse in the ED, you've got that client with an MI. Which medications would we include in the plan of care? So select all that apply. We have A, that unfractionated heparin. What do you think? Go ahead and shout it out. We're taking it one at a time. Heparin, do we give it? Yeah, it prevents that clot from growing by stopping clotting factor activation. It's kind of freezing the problem, keeping it in place so we don't get worse while we work on a solution. Now, option B was nitroglycerin. Yay or nay? Do we give nitroglycerin in an MI? Yes, if there was one you already knew, it was probably that. Remember, nitro relaxes and dilates the vessels, which decreases preload and myocardial oxygen demand. Basically, it's going to open up that highway so the heart doesn't have to push as hard. And we know if the heart doesn't have to work as hard, that ischemia isn't as bad. Next medication is isosorbide mononitrate. Would we give that in the case of an MI? I know we didn't in our case study, but would we give it in any MI? We would not. It actually does not belong here because it acts too slowly for an acute MI. Answer choice D was aspirin. Yay or nay, would we give aspirin? Absolutely, that's a yes. We are going to go ahead and give 325 milligrams of a chewable aspirin to slow down that platelet aggregation, stop them from clumping together so that more oxygen-rich blood can reach the damaged myocardium. Answer choice E was diltiazem. What do you think? Could we give that in an MI? No, you really don't ever want to give diltiazem because it can worsen outcomes if we have left ventricular dysfunction, which is very possible in an MI. So that one is a no-go. And lastly, answer choice F was metoprolol. Yay or nay on the metoprolol, would we give it? Yes, remember it's all about making that heart work easier, lowering that myocardial oxygen demand, and metoprolol is a cardioselective beta blocker that is going to slow the heart and reduce contractility. So by keeping it calm, we use less oxygen. All right, so that was a lot of interventions. Hopefully the recap and the practice question helped. I am going to leave you with one little memory trick since I took Mona away from you, since we don't always give the oxygen. We have now transitioned to on time. So we do give oxygen if that oxygen saturation is less than 90. The N is for nitroglycerin. The T is for thrombolytics if we can't get to a cath lab for PCI. The I for those antiplatelets, aspirin or clopidogrel, so we don't have that platelet aggregation. M for medical management and monitoring. These are things like your beta blockers and your heparin. And very importantly, if not the most important, E is for ECG within 10 minutes. Now, you need to know these interventions like the back of your hand because every second really matters. Heart tissue does not regenerate. The faster we restore oxygen, the more muscle we save. And that's the difference between recovery and irreversible damage. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.